getting feedback. I'm the chair of the TAC, and I welcome everybody to the hospital TAC meeting. She says, Elaine and Lori, do you want to introduce yourselves?
Sure. I'm Elaine Yance from the University of Kentucky.
Good afternoon. I'm Lori Ritchie Baldwin from St. Elizabeth Healthcare.
Okay. And who from DMS do we have?
Angie Parker.
Hi, Angie.
Steve Bechtel.
Justin Derringer.
Amy Richardson.
Judy Terrio.
Jennifer Swingle.
It's Kelly Keith again, and I'm sorry, but I would like to remind the TAC members that when you are voting, in order to comply with open meeting laws, you must have your cameras turned on.
Thank you.
You're welcome.
Okay, we have the minutes from the previous meeting. They were sent out. Does any of the TAC members or anybody from DMS have any adjustments?
I don't have any.
Okay. I have a motion for approval of the minutes.
This is
Make a
Lori. I'll
motion.
make a motion.
Second.
Sorry, Lori, this is Elaine. I'll second.
Okay. All those in favor? Aye.
Aye.
Okay. Minutes pass. Old business, Molina Emergency Department claims policies. So this is an old item that we've had on the agenda for several meetings. I still have not been given the policies to kind of refresh everybody's memory. There were an emergency department policy was approved by DMS, and I know there's been medical records requests that have gone out to providers. I know I've received those, and I've asked, and when we asked questions about the process, and we were told from Molina that there would be policy clarifications that would come out. And it's been about 6 months at least, and I've still not seen those policies, and I'm asking again for those policies. Anybody from Molina can answer that question?
Hey, Russ, I'm sorry, I was transferring systems. Can you repeat the question for me, please? This is Nicole Bash, I'm sorry.
Yeah, so the Molina Emergency Department claim procedure was approved by DMS. And when we started to ask questions about 3 meetings ago, Molina said that there were clarifications of some things that were included, not included, and to be reviewed. And I know I've gotten medical records requests under this policy, and I've asked repeatedly, not only of my own rep, but at this TAC meeting, for the clarifications of the policies surrounding what Molina is doing on these emergency department claims.
Yep. So, Russ, we're happy to meet with you. I know that the team has sent it out, maybe to your staff, maybe didn't get to you, kind of the high level criteria that we're using to identify those. There was a misstep on the KJ call that occurred a couple of weeks ago around whether we make any payment at all. And so that's getting corrected, making sure that everyone is aware that if anything is agreed upon to be non-emergent, we are paying up to $100 for that visit. And so, again, we've published everything that we have to publish, but I think I've also offered, I'm happy to meet with you and talk through it if you've got some more detailed questions, or to recirculate the things in the items that we've been able to send out.
So I'd like you to send them to DMS and then for DMS to review them as well, but I'd like it to come from them, so it goes, so we need to make
So-
sure that we,
Yep.
the appropriate
It's
stuff.
all been to DMS for approval. So you're asking it to come from DMS?
Well, the policy is one thing. There were explanations and clarifications on that policy that we've been asking for.
Mhm.
Um,
That's been to them as well as part of kind of the high level criteria.
So do you know when that was set?
It's been back in January, so I can recirculate that, Russ. The criteria hasn't changed.
We had a meeting in February
Mhm.
and we asked for it again and we were told it wasn't ready. I asked my rep about a month ago or so, a month and a half ago for it, and we were told it wasn't ready.
Okay, let me get this prepared and I will send it on certainly to you, and then I'll chat with Jeremy at DMS
Okay.
to see.
I can send you those emails and I can bring you the
No, it's
minutes from the last meeting when they said it was not ready to be viewed and they were still working on it.
Yeah, no, I'll get it out to you, Russ, and so we can get it distributed to everybody.
Okay,
So
thank you.
I'll circle that loop. Again, this is Nicole Basham. I'm the VP for Network and Operations. So we will close that loop for you.
Thank you.
You're welcome.
Any questions from TAC members? Okay.
No.
Incarceration data, I know I continue on the KHA monthly calls to hear noise around incarceration data and issues. I know we've been working on this for a while and I know it has improved. It's just any update from DMS on any other further effort or improvement.
Hey Russ, it's Claire.
Yeah. Hey, Claire.
If I may, just one thing to add to this that came up in the membership call yesterday, it was more kind of an expectation around how the providers are to get the patient to sign the MAP form. And so that's going to come up on the DMS MCO call on Friday, but I just wanted to bring that up here. The members have been complimentary of, the improvements to the incarceration issue and have appreciated all of DMS hard work on this, but that was just one point of clarification on getting the form signed.
Okay. And we'll table this, and if you have additional information, Claire, from that needs to be discussed, we'll discuss it.
Thank you.
All right, new business, Optum reviews. So we've had repeated feedback from providers about some of the vendors, particularly Optum, that the MCOs are working with, and two particular issues. One is requests for medical records are not going to the correspondence address from Optum on multiple MCOs. When the providers find out that those requests have been made either through a denial, a technical denial, they realize that the requests have gone to the wrong address, either to a clinic office or another department that is outside of the correspondence. And when they bring it back to the MCO, the MCOs have repeatedly told them to go work with Optum, and they've not been able to work with Optum successfully. So it is, it's not, I don't think it's the provider's issue to make Optum do what they're supposed to do. The MCO should handle their vendor and make sure that what they're doing is appropriate and the requests are going out to their appropriate addresses. It's causing delays in payment, and I guess, my take on it is that, that if I held something for 30 days that I'm not supposed, that I missed something or I did something wrong, doesn't matter if I sent it to the wrong address or not, I'd get a technical denial. So I don't think, I think that needs to be addressed, but at a minimum, any delay in payment should have, due to the issues of the vendor that's working for the MCO, should have interest attached to it. So unfortunately, we've got to ask DMS to step in and provide guidance to the MCOs because we can't get resolution from the MCOs to handle it the right way.
Hey Russ, it's Krista from UHC. Good to see you.
Hi.
If there are any of those examples from a UHC perspective, I'd love to get those so I can pop my email address into chat. But if I have specific examples, I can go chase it down from a United Healthcare perspective.
Hey, Russ, ditto for Melina. I'm doing the same.
Yeah.
Same
That would
thing
be
for Humana.
Okay. So everyone in the chat, you're getting emails there for contacts for Humana, Molina, and United. What about WellCare?
Also,
Your rep-
Anthem.
WellCare on?
Yeah, I just dropped it in there, Russ. It's Stuart Owen.
Thanks, Stuart.
Sure.
Also, Anthem
Got
as
that.
well. I'll drop mine in the chat.
Okay.
Aetna as well.
And I know this was an issue several years ago where we had this in kind of a mass, but I think with some of the new vendors, it's starting to pop up again, and we had to work hard to get the correspondence address, make sure it was populated everywhere. But if it's coming from a vendor, I would ask that the MCOs help get those corrected for those folks. All right. Any TAC members have any other input on this?
I think you covered it, Russ.
Okay, thank you. Okay, sepsis 2 versus sepsis 3. I got a letter, Justin, I think you signed a letter from June 13th on sepsis criteria for the hospital providers, outlining that sepsis 3 was to be used for utilization management.
Yes, that is correct.
Okay, so can you clarify when you say utilization management, what exactly that means?
Yeah, I'm gonna let Dr. Terrio, can you, I'll let her explain a little more about, or to go in depth a little more about what we mean by that when we talk about the use and how it's used. It's actually, or if she'd like to, I don't know. I think she's on here, but we use, or all the different providers use different criteria for their utilization management. We used to allow for multiple providers and vendors, and some of them use sepsis 2, some of them use sepsis 3. And so, for a long time now, we've been, more and more of those have been moving to the sepsis 3 criteria. And I think we're trying to kind of stabilize that so that everybody's kind of on the same page.
So we
As
went
far
through
as the
this
hospital
before.
provider type.
Yeah, we went through this before for coding and reimbursement, and we had multiple meetings with Dr. Terrio and the memo that came out in 19 basically said that they would follow the DRG, CMS, and the ICD-10 definitions until CMS had adopted the sepsis 3 criteria. And CMS has not adopted the sepsis 3 criteria.
Hi, this is Dr. Terrio. That's correct. But over the last 4 years, more and more of the time people are using sepsis 3. And so we've gone ahead and switched. Now you can to sepsis 3 as of June 13th.
Okay.
We have now, I don't know if it's Milliman or Interqual. I think it's Milliman has switched to sepsis 3 as well. And that's one of the guidelines that we use for RUM.
So let me ask you some clarifying questions. I know when you say it's being used in the medical community, but from coding guidelines, coding indexing, coding clinics, you've got CMS, AHA, AHIMA, NCHS have all cooperate in those in the coding piece, and they've not removed sepsis 2. They still utilize sepsis 2 for coding, not sepsis 3, correct?
Correct.
And
As
so
far
from
as
a coding,
utilization management, it is,
well,
it's more,
the letter says coding and reimbursement, so I'm trying to clarify from a coding perspective, are we supposed to not use sepsis 2 in coding? Because that would,
I would go
so-
with sepsis 3 criteria for that, for coding and
Okay, so-
reimbursement.
So from a coding perspective, ICD-10 still uses sepsis 2. Without you're going to have different codes for. So the reg, as I read the inpatient reg for the indemnity, requires CMS diagnosis codes for that because it uses the CMS grouper and CMS payment. So you're going to have different coding for indemnity versus the MCOs. And then I guess, my second question, I got multiple, is that from a coding perspective, what kind of grouper, because the CMS grouper that most of the MCUs use is based in sepsis 2, so how are cases going to be grouped and ultimately paid because there isn't a grouper that is being used that has only sepsis 3 that drives the DRG assignments.
So you said there's a grouper that uses sepsis 3?
There is not, to my knowledge,
okay.
not a CMS grouper at least.
That I don't know. I'd have to kick that back to Justin.
Yeah, I had to take that back and look at, ask our coding people, because I'm not the coding specialist. They have all that. They have all that information when we looked at this originally, but I don't have that information right in front of me, so I have to get that back to you.
We need to know, because this is going to be a big issue for the providers. I mean, I've asked repeatedly from the cabinet side to utilize the TAC and include us when the decisions were being made that impact the hospital community. And I don't know anybody from the TAC that was involved in this. And so number one, you're going to have, we don't code, it's going to be an administrative burden. We're going to have to code MCO cases different than every other payer in the world from Medicare, which we don't do now. They get put in a bullpen. So we're going to have special processes to do that. There's no grouper that it can group to, so I don't know how the MCOs are going to pay. You're going to have Medicare and Medicaid indemnity versus MCOs look different, have different data, have different quality outcomes. So when you have sepsis 3, you've got to have organ dysfunction to get to sepsis 3, right? So you're going to have a lot of cases that when you look at everybody else in the world from Kentucky MCO cases that are using CMS and sepsis 2, their populations are going to look different from a quality outcome. Observed and expected mortality, lots of different things that I can think of. On the HRIP, we're trying to push to identify sepsis early, but with sepsis 3, there is no sepsis, and there is no sepsis. There's just extreme sepsis when you have organ dysfunction, so there is no sepsis. So it's kind of in conflict, at least from our clinicians' perspective, and what we're trying to do on the quality with the HRIP. So there's a lot of concerns with this, and I'm going to ask you to pull it so we can have further discussions, because I don't think it was thought out and all the impacts that it has.
Well, I know we're starting, the policy will go into effect on the 13th of June, or did go into effect. We can bring it back and talk about it. I can talk about it with Justin a little bit more and see what else there is to talk about.
Yeah, like I said, let me take that back to some of our coding and billing specialists. I don't have that information in front of me. I know we looked at all that when we originally started, so.
Administratively, none of your MCOs have any way to pay a DRG correctly with just a sepsis 3. And know what to group it to. Especially if they're, I mean, it's going to be, I mean, I'm going to, others from the TAC want to chime in? Anybody else have anything to say?
Yeah, Russ, it is an out of process. It's hard to administer because it's out of our normal process.
And I know Milliman may use 3, but Interqual still use 2. I mean, you've got those 4 agencies that have worked on coding guidance, and from a coding perspective, it goes against all coding rules. I mean, CMS has recognized sepsis 3, but they have not adopted it. And these are a lot of the same things that we talked about in 2019 and why we got to the place that we did, because you're going to have the MCO claims that are different than the indemnity claims and the MCO claims that are different than any other Medicare or other claim that you're comparing them to. The MCOs don't know how to group it, don't know how to pay it. Contracts are their contracts. I have 5 contracts that are in direct conflict with this letter. I terminated an MCO for this specific issue, and I will again. So, Angie, you've got, I mean, there are issues here, and I guess, again, I'm asking you guys to pull it, and we'll make a recommendation if we have to take it to the MAC, but discussing it when there's these type of problems with it, when it's not been discussed with the hospitals and TAC before this, is a problem.
Yeah, and Russ, you mentioned it, but kind of the maybe unintended impacts associated with it, there's a lot of them.
Well, there is. And again, that's why we've asked repeatedly to DMS through this committee to include us in decisions that impact the hospital community, to use us to have discussions with us. I've asked it. I've said it multiple times, and it was not done. And this is what we get.
Well, best I can do right now is to bring it back and we'll talk about it internally. And we will get back with you guys.
Okay. I guess the TAC members, I would make a recommendation to the MAC that DMS repeal hospital provider letter dated June 14th on sepsis criteria PLA 263, based on the discussion that we've had here today.
Russ, do you need a motion to that or just our acknowledgement of our agreement?
I made the motion. Is there a second?
I'll second.
All those in favor?
Aye.
Aye.
Any opposed? Motion passes. And Justin, Dr. Terry, I'm more than happy to meet, and I know some of the other TAC members and their medical directors would be more than happy to meet to discuss the issue.
Yeah, like I said, I need to take it back and get some more specific. I apologize, I don't have the specifics on the billing codes. I mean, as far as utilization management goes and using that for prior authorizations. But as far as some of the specific billing questions you have, I don't have that off the top of my head, but let me take that back and get with some of the people that do that, and we'll reach out to you and we'll meet.
I appreciate that. Like I said, ICD-10 uses sepsis 2, and again, it's kind of not in concert with what we're trying, the quality measures that we're trying to chase on the HRIP either. But I'd appreciate dialogue and conversations.
Okay, we'll get back with you. Thanks.
Okay, any other items from the TAC members that you want to bring up? Elaine, Lori?
I don't have anything at this time.
I don't have anything either, Russ.
Okay, we made the recommendation. The MAC meeting, I will be at the MAC meeting to represent the hospital TAC. Our next meeting is August 22nd, 2023. And barring any other issues, motion to adjourn.
I'll make a motion to adjourn.
I'll
All right,
second.
Thank you,
Thank you.
everybody. Everybody have a great
Thank
day.
you. Thank you. Bye.
Thank you.